what we're going to be talking about is Proconus single-shot spinal anesthesia for the morbidly obese. So while we consider this, let's get an idea. So we have a morbidly obese parturian who's presenting for cesarean delivery, and it's going to be elective because she doesn't have an epidural in place. Who here would do a spinal anesthetic for this individual? So it's single-shot spinal anesthesia. Raise your hand. Okay, who would not? All right, so we have an idea there as we go into this. And just as feedback, when Brenda and I were doing this, I actually had the con, and this one really is true. As I was reading the literature and going through it, I called him up and I said, Brendan, you know, I hate to admit it, I really would do it. And he goes, that's fine, I would love to switch, and we traded beforehand. So I'm going to let Dr. Carvalho fill you in on the wrong stuff, and then I figured I'd go last to correct his errors.
So clearly he's trying to butter me up, but it ain't going to work, unfortunately. So I'd like everyone to take a seat, because you're in for a long and somewhat bloody battle here. The truth is, I'll just obviously before I start some disclosures, I also want to disclose that what is said in debates are extreme views, more for comic relief to some degree. And I am from South Africa, and we didn't really become politically correct yet, so there might be a few things, and I hope I don't offend anyone along the way. All right, so we clearly are taking completely opposite views on this, and probably because of our geographical locations, we're opposite ends of the United States. And I'm going to show that the con, or i.e. do not do a single-shot spinal, is absolutely the right way to go. Now, you've already met Bob Gaiser, and he comes across as an extremely good speaker, entertaining, knowledgeable about anesthesia. I know firsthand that he's a superb caring physician, but this is what he actually masquerades, because the truth is anyone who is prepared to do a single-shot spinal on a patient like this clearly lives in a completely different reality from all of us. Now, maybe he just lives in fantasy land, maybe he's just particularly cruel, I don't quite know, or perhaps, but I'm not totally sure, he's just trying to be funny. But who would actually consider doing an anesthetic like that? Because this is a real big problem, and excuse the pun, but in 1989, this is the CDC data, about 10 to 15% obesity rate around the United States. 20 years later, this is what the graph looks like, such that 1/3 of the United States population is overweight and 1/3 is obese. And it's very clear that the problems are not going away and that we have to deal with it. And it seems like there's been an inverse relationship with the size of our televisions and the size of the people around. So I showed you one graph and trend change, but what's probably the scariest trend change is the growth of the super obese. So this is not just a BMI of greater than 40, by definition of the WHO, but it's that about 50, the really large patients. And unfortunately, you know, the title of this talk was Morbidly Obese. It includes the super morbid obese, because you go straight from greater than 40 all the way up. So I have a feeling you may start arguing the different types of obesity and different distributions. And it is true that certain fat distributions make our lives more difficult. So for example, the gynecoid shape can make neuraxial placement very difficult. Equally, the android fat distribution can make the airway management difficult. So fat distribution is probably even more important than overall mass, BMI mass, but nevertheless, we have to take it as the topic, which is greater than 40 or morbid obesity. So very simple in one slide, why should you not do a single-shot spinal for a morbid primigravida? And the basic reason why you shouldn't is it is almost impossible to know what intrathecal dose to give. And if you give too much, you get a high or total spinal. And if you give too little, you have a failed block and you have to convert to a general anesthetic. So let's start with too high a block. So this is seminal work by Hogan, published a few years ago, where they were looking at difference in CNS volumes amongst obese and non-obese patients. And what they showed is in obese, probably because of abdominal compression, that you have less CSF volume, and if you have less CSF volume, the drug that you give within the CSF is going to have a greater effect, or at least that's the theory behind it. And it led to a lot of recommendations for why we should reduce the dose. But what is not well highlighted in this particular study is the next graph, which is also looking at area, it was a way of dividing the CSF volume from the actual cord volume. But if you look at the graph, just note the variability. So this is the different levels as you go down the spinal cord, and they did sequential measurements as you go down. But look at the variability. It's, if you look over here, look at the difference amongst individuals within different areas of the spinal cord. So not only do we not always go consistently where we put it in, but in amongst the patients, there was a huge amount of variability. And I'm going to show you this data clinically and how it can actually affect everything. We do know that there is a very strong relationship between CSF volume and block height. Okay, so that work that I just showed you with CSF volume does correlate to clinically meaningful outcome measures. So what about the risk of a high spinal? So this is in non-obese patients, but a group decided to try and evaluate what degree of risk. And if out of their 600-odd spinals, they had one case of a high block, so the incidence was 0.2. Now, this is a slightly different topic, but if you look at this 11%, those are patients who have existing epidurals, failed top-ups, or the epidural doesn't work adequately, and then they do a single-shot spinal. And they had 11% risk of a high. So in that setting, most of us really need to be cautious about doing a normal single-shot spinal. The reason why I show these two statistics is the next slide. So this is the SCORE project. You've heard a lot about it at the meetings, but there were several reports of high spinal. And if you look at the risk factors, the predictive risk factors of a high spinal in the cohort that reported high spinals, obesity was the leading cause of high. So 86% of high spinals in the reported SCORE project could be explained by risk factors, and of those, the overwhelming majority were obese patients. And if you go one step below that, the spinal after a failed epidural was below obesity as a risk. And if you see the slide before, that was the 11% risk. So obesity is actually adding risk above a failed spinal that goes to a single-shot spinal. The other issue is that obese patients just don't handle high blocks like non-obese patients. This is a really good graph from a really good review on obesity and pregnancy. But if you look at the combined effect of obesity on top of pregnancy, you can see how it affects your ability, your respiratory capacity ability. Specifically, your residual capacity is reduced significantly. There's more work and compliance of work and decreased oxygenation. All of those extrapolate to if you do have a high block, patients don't manage. And not only do they not manage, they eventually land up like one of our patients, intubated and ventilated. So a lot of you look at this and you think it's just a general anesthetic for a morbidly obese patient, but I view this as Bob Gaiser's single-shot spinal technique. And you might say, well, you know, this is a success story, the patient's intubated, but the truth is the obese pregnant airway is a very, very scary place to be, and it is well documented that it shows you difficult mask ventilation, more difficult intubations, especially with the android distribution of fat, so the neck circumference. They desaturate very quickly, there's an aspiration risk, and the risks don't just end on intubation. So you can see what an issue it is, and if it's been well highlighted, and this is from the confidential inquiry from a triennial report where they actually noted that most women who came of harm of the 6 deaths, 4 were obese, 2 morbidly obese. So obesity does eventually result in harm. So that's what happens if you give too much of a dose, and there is concern that you are going to get a higher dose with obese patients, and I hope I've sort of demonstrated that adequately. So in an attempt to prevent getting too high a dose, then you reduce your dose. And what happens when you give too little? So I believe in giving 100% with most things I do, but in a setting of an obese patient who is likely to have a higher block, and I've showed you evidence of why that may happen, especially with the reduced CSF volume and the clinical correlations of that, you do need to reduce your dose, is the recommendation. And it's not just my recommendation. The vast majority of textbooks, if you go and look, will recommend in obese patients to consider reducing your dose for morbid obesity. And I'll show you a demonstration of, from the Wake Forest group. They reported a case where they did a CSE technique to their credit. They gave 5 milligram dose, 5 milligrams intrathecal bupivacaine in a patient with a BMI of 66, and they had adequate anesthesia throughout the case. They did not need to do an epidural top-up. So this is a demonstration of how much you can reduce it and get away with it. But there is a big problem with reducing your dose of intrathecal morphine. There are 2 meta-analyses that have looked at studies that promote low dose versus high dose. And again, these are studies not done on non-obese patients, but the message is fairly clear if you look at it. So the one meta-analysis used the cutoff of 8 milligrams. And if you look at that, your analgesic, the likelihood of needing analgesic supplementation is 4-fold increase when you start using doses of 8 and below. So every 4th patient gets harmed because of this. You require general anesthesia conversions, and yes, you get less hypotension and you get less nausea because of the smaller dose, but look at what you create. In a slightly different meta-analysis with just a different endpoint, again, you see the analgesic supplementation with a small benefit of decreasing hypotension. So reducing your dose has a cost. It has a cost to a patient, and I showed you the slide in my talk yesterday about preference, and in fact, Alex Macario, who just presented, was involved in the study. But pain during cesarean section is the biggest concern for patients, and it's something we need to address. We did a retrospective review of our obese patients, but what is apparent with all the cases that we do for cesarean delivery is the surgery goes on for longer. So if you're reducing the dose for a normal cesarean delivery, you've got to expect that in a morbid obese patient, the surgery will continue for much longer, and you're more likely to have failures because of that, and I'll show you the study in a little while. So you reduce your dose, the surgery goes on for longer, you have inadequate block, and then you land up, surprise, surprise, exactly where you were if you'd chosen to give a larger dose. So you get this, and again, like I mentioned, it's Bob Gaiser's favorite technique for these patients of giving a single shot spinal. You do this, you land up having the airway issues, and again, potential morbidity associated with it. So what are better anesthetic options? It's easy to criticize one particular option, the single shot spinal technique, but there are a whole host of different options you can come up with. And clearly of all these options, there's only one that's really wrong. You have to do a catheter-based technique for these patients. All the rest are options, and you can see this cartoon. Clearly the CSE is the 2 + 2 = 4, and the other 2 options are clearly not quite the right way of doing it. So why is a CSE the best option? Well, obviously Hannah Montana knows exactly. It's because it's the best of both worlds. You get the benefit of your spinal, which we know gives you a quick block. It gives you reliable anesthesia, definitely better than an epidural form of anesthesia. And then you have the flexibility of the catheter. So if you happen to reduce your dose to prevent those problems of high block, you're able to supplement the block, or if your surgery goes on for longer, or there's unexpected issues, you're able to utilize the catheter. Now, what Bob may tell you is that you're dealing with an untested catheter. Well, actually, before I go to that, let's talk about how useful a epidural technique can be to push up your spinal block if you use a reduced dose. And this is fairly popular in Europe. It's called the sequential CSE technique, where you deliberately use a smaller dose of intrathecal medication and let your epidural push it up. And it is probably just a volume effect, because this has been shown even when you use saline, you can push it up 4 dermatomes, but equally you can use local anesthetic. I don't necessarily promote this technique, but it just shows you how effective an epidural can be to augment your spinal. There's debate about why that happens, if it's more of a pressure or a volume effect. It does allow you with a sequential technique to get your opioids in. We spoke how important a lipophilic opioid is to improving your local anesthetic and your anesthesia, and that opening up that dural hole confirms placement and allows your epidural catheter to work better. And we were talking about failure rate of an untested catheter. So there's a lot of reviews on this. I think one of the better ones is the maternal fetal medicine unit looked at 37,000 women. And you can see the failure rate with spinals and CSEs are equivalent and half that of an epidural. And in the biggest cohort of the lowest failed top-ups for C-section, these are laboring patients who go to C-section, there is a good evidence that the CSE is less likely to cause failure, and the biggest cohort that looked at it with the lowest rate was Alexia's group in Singapore that had a 1.7. So you can see that 1.7, around 2% failure rate. Both the spinals and CSEs are the same. So the concern that you have a catheter in that's not going to work when you need it is unfounded. So I think by doing a single shot spinal that you're heading the wrong way. Even at the time you might think everything's okay, but you don't have a way of bailing out if something happens. And the biggest problem is the consequences of failure are huge in a morbid obese patient with an airway issue. Now what Bob is going to try and tell you is he knows exactly what the right dose is to give. So what exactly is the right dose to give? So clearly I've shown you if you give too much, you're going to have a high block and issues, and if you give too little, you're going to have an inadequate block. So perhaps he knows just the right amount to give. Well, we've actually tried to determine scientifically what the right amount to give, and I'll show you some data to show you how impossible it is. So this is data from a non-obese patient. So what the study design was is to use logistic regression to determine ED50, ED95 levels of what is required to get good surgical anesthesia for cesarean delivery. Non-obese patients getting intrathecal doses, you can see it starts off at around 6 and goes all the way up to 12. You have a CSE technique because it allows you to bail out if you don't have adequate block. The gray bars are adequate initial levels, so this is a block to T6 from your initial spinal, and then the black lines are not only do you have an adequate level initially, but you don't require any top-ups during surgery. In other words, you don't report pain or you don't request additional analgesia. And you can see from 10 milligrams onwards in a non-obese population, you get success both with initial block and ongoing subsequent block. And if you do a logistic regression analysis, you get a ideal dose of, if you round it off, 12 milligrams. And that's why it's a dose that's largely promoted for C-sections. So the same study design applied to obese patients. So the top diagram is morbid obese patients compared to that historical control. So what is apparent when you look at same study design, what we actually did, slight alteration, it started at 5 and went to 11 because we were a little concerned with that higher block. So we could at least shift it down a little bit. But with statistical analysis, that slight shift makes no difference. If you look at the red bars, that same initial block height to T6, and you can see even with really low doses, you are able to get initial block that looks adequate, but they all failed. There was no 100% success rate, even in the larger doses. So what happens is you get this false sense of security because you give your initial dose, you get what you think is an adequate level, but that is not good enough for surgical anesthesia throughout the case. And it's a big concern that you can get misled. And what this data also implies is that for obese patients, that initial dose, you need a reduced dose. But for ultimate success of the surgery, because it's more technical, takes longer, there's more pulling and longer change of position, takes longer to get a patient from sitting to flat. All of these contribute to why it may fail later on. So what were our conclusions from the study? That we actually thought we would show that you need less dose, given the theories behind which I showed you, Hogan's work in the CSF, etc. But we actually said, no, there was no evidence for dose alteration. But the clear take-home message is the variability in response. And remember I showed you Hogan's work with looking at the variability, comes and shows good clinical applicability of obese patients and how much variability you get. And the only take-home message was patients who are morbidly obese undergoing cesarean delivery need a catheter-based technique to guarantee surgical anesthesia throughout the case. It's not just the work we've done. This is another study looking at obesity, obese versus non-obese. They came up with around the 12 milligram dose, which I've mentioned before. But the thing to highlight, which is most interesting, is look at that confidence interval in the obese patient. So the non-obese patient, you've got a really nice, tight confidence interval around 12. But look at the morbid obese patient, to infinity. I've never actually seen how you can get to infinity, but clearly they were unable to get it. And again, just shows you that variability in response. And I mentioned that slide, Hogan's work. It's no surprise that you get such variability when that's what's happening in your CSF. And I'll end with this slide. This was work was done by Mark Norris a while ago, and they were trying to look at the relationship with obesity and analgesic and anesthetic levels. And basically, there's no relationship. If you look at the R-squared coefficient, basically none of the variability in block height, both for the anesthetic level as well as surgical anesthesia, was explained by BMI, which again goes back to this. Such a lot of variability that, yes, maybe as a whole cohort there might be differences in needing a smaller dose or a larger dose, but the variability makes it almost impossible to predict. And at Stanford, that same retrospective study I mentioned, when we're looking at our technique, we start to use more and more CSE techniques, and what's really scary with that statistic is almost a quarter of the cases we actually required it to bail us out, despite the best dose prediction in our morbid obese population. It clearly isn't a problem before you get to the BMI of greater than 40. As you can see, this study dividing it into quartiles of less than 30, 30 to 35, 35 to 40, and then 40 and above. So, in conclusion, it is inappropriate to do a single-shot spinal, either a reduced dose, full dose, whatever dose you think you can do. It is a catheter-based technique for two reasons. Number one, variability of response, and number two, the price of failure is too big in morbid obese patients because of the airway and everything else that can go wrong. So this is a perverse way of looking at this, but I find it pretty funny. But actually what he was really trying to say in this photograph is this. Thank you very much. You want to stay up?
You know, all I can say, Brendan, is wow. You almost had me convinced. And I thought it was pretty cool that you started with a picture of California and Pennsylvania, because I definitely remember when my daughter was applying to colleges, she told the guidance counselor she would like to go to Stanford. And I was just so pleased when the guidance counselor said, "Oh, you mean the University of Pennsylvania of the West?" And I said, "Outstanding." So, great. So what we're doing here is, again, it's not just we're looking at single-shot spinal anesthesia. We really, you know, as he said, he started with taking a look at Pennsylvania and California. And I know right now we're standing here just a little bit before lunch, right? And we're starting to get a little bit hungry. And so what does California have? They offer you these California rolls, right? Not so good. Come to Philadelphia. We'll give you the Philadelphia cheesesteak. And by the way, this Philadelphia cheesesteak, it's a business. You go any hour, you're going to wait about 30 minutes in line to get. You have to eat outside, and it's a totally cash-only business. So, and that's Pat's. So you got your choice. Choose the California roll, or come to my side and get the California cheesesteak. Or how about this? How about the heroes of the state? The hero for Stanford here is Kim Kardashian, right? You know, that's the Californian. Hey, Rocky, right? Who do you want to go with? And that's all I can say on that. So I have no financial disclosure, no off-label use, and what I'm going to do is review a little bit of spinal anesthesia in the obese as we try to decide whether it is an appropriate technique for our patient. And I think that's the most important take-home for this. We want to synthesize the data to come with a valid conclusion. We're going to understand the risk of performing spinal anesthesia in the obese participant and decide whether it is appropriate to use single-shot spinal anesthesia in the obese. So I want you to remember everything that Brendan said, because it's really important. Because when you think of what Brendan said, the only thing I can think of is I have to quote my hero, who would be standing there going over there and saying, you know, look at how she is looking down at Brendan there, sitting there saying, Judge Judy, if it doesn't make sense, it probably isn't true. And we have to remember that because there was a lot of stuff that he said there that just doesn't make sense as we go through that. And the other thing I want to remind people, you must remember one of the comments that Brendan made yesterday when I was hosting the first panel. If you remember very correctly, it was Dr. Carvalho himself who said, "I am a hypocrite." You did say that, didn't you? So, let's take a look at some of the... Now, you got me laughing. Let's take a look at some of the considerations in the obese parturient. Well, we know obesity definitely increases the risk. These are going to be risky pregnancies. There's a higher risk of gestational hypertension, a higher risk of preeclampsia, a higher risk of gestational diabetes, and the worst case, there's a higher risk of cesarean delivery. So when we look at this cesarean section rates, and this is coming from data, it's a little old, but when you look at this, you know, the trend constantly keeps going up for the obese. When you look at the obese, it goes from 20 to almost 35%, and it climbs to almost 50% for those morbidly obese. And that's defined as greater than 35, and I'd argue that's not morbidly obese. And I think this is interesting. So as we start to see this trend in obesity, realize these patients are going to present for cesarean delivery on that. The thing that I thought was interesting and wasn't touched on, and it was addressed a little bit today, and you can tie this into Dr. Fragnetto's talk, obstetricians really have no understanding of the anesthesia risk with the obese parturient. So what they did is they sent a survey to all these obstetricians, and they said they were very likely to talk about their high risk of C-sections, but the only thing they knew, the only thing the obstetricians knew about anesthesia risk, it is harder to get an IV in. That's it. Few knew that obesity was associated with failed epidural. Few knew that it was associated with a patchy epidural, and few knew that it was associated with difficult intubation. So, another really important point that we heard from Dr. Fragnetto's talk this morning is communication is key. Because what Brendan and I are agreeing, these patients are definitely high risk. And the sad part is, our obstetric providers are not aware of this, and we have to remind them. The only reason they know that the risk of the IV is because they're waiting, and we're trying to get the IV, and they see that. But we have to be very careful and educate our obstetric providers that are risks. And what you see here is the whole list of risks that they asked about, and as I said, the only one that they were aware was that it was a difficult intravenous access. And I'll definitely agree with Brendan that obesity will increase the duration of cesarean delivery time. So the length of time it'll take to do a cesarean delivery will be longer for the obese group. Here's a retrospective cohort. This comes from 2013, and they're looking at 4 different comparison groups based on the BMI. And you can see as the BMI goes up, the length of time to do the cesarean delivery does go up. And what they're looking here is this is the induction to delivery time. Now the hard part in that's not including then the closure time, which we also know will be prolonged in this patient population. So I'll have to give him 1. Check 1 for Brendan, because we are both agreeing that cesarean deliveries are going to be prolonged, and we need to remember that when we're designing our anesthetics. So here's taking a look in groups. So it's a very large study. It comes from Gaiser. And look at the number of patients who got spinal anesthetics. This is almost close to 1,200 got single-shot spinal. Epidural, about 1,000. And looking at the weights. And so, we're, I'm going to back up here. Here you can see the 40 kilograms. You can see a good number of them had spinal anesthetics in that regard. And I think we see in this case, we definitely know there's a longer operative time, but I think the impressive thing in this group is look at the time. So no question it went up. It went 43 to 55 minutes. So you take a parturient at my institution who's 70 kilograms, and we can't even get it under 2 hours. When I was listening to Alex, where he was talking about a C-section that's 90 minutes, I'm like, sign me up for Stanford. I've never seen that. And I think the key to this, while they talk about the length, it is, I argue, a little deceiving in that, because I don't believe, and this is, when they report the average, and what you'll see is there's a wide spread, and that is, I think, one of the hard parts, and both Brendan and I are agreeing, it is difficult to predict. And as Brendan would say, after that, I need a drink. So let's, rather than sitting there and talking about this, let's just ask Brendan himself. What did he publish? He has an anesthesiologist. Cesarean delivery is the most commonly performed under spinal anesthesia. And we won't correct him, because at that point it should be during spinal anesthesia. It's not going under the spinal. But during spinal anesthesia, hyperbaric bupivacaine. Bupivacaine provides an appropriate duration of anesthesia to perform cesarean delivery. So he wrote that. I don't see an except. Do you see an except there? There was no little dot where you're supposed to go underneath and say, except in the morbidly obese or in the obese. It is the ideal form of anesthesia, according to my colleague. I don't even have to say anything. He's already told me it is the ideal. But can we prove this? Well, let's look a little historical perspective. So this study gets quoted a lot because it's 1993, and it was considered revolutionary because at this time period, we weren't encountering many obese. So this is probably the first taking a look at the anesthetic implications of caring for the obese. So you can get an idea. So this is coming from Wake Forest, and it was data collected on 117, so just 117 women. And you can see the average weight of these women were 136 kilos, so they're obese. 62% had cesarean delivery, and that means so 72. And you can see only 4 had spinal anesthesia in 1993. The control group, 7 out of 28, had other forms of anesthesia, and what they used was these 24, 26 gauge Quincke needles, and there's been changes. There were fears of inadequate spinal anesthesia, length of operation, and excessively high block. So the concerns from 1993 are no different than what Dr. Carvalho is trying to convince us is going on today. And if you remember 1993, that was the era of Waco, as well as when River Phoenix committed suicide. So there's 1993. So the group said, well, we're going to take a look at what's happened now in 2013. So got published 2014 because they said it's a little bit different. So same location, Wake Forest. 230 patients, so we're seeing more, and again, the weight is greater than 136. 55%, again, no surprise, because we said, remember, high risk of cesarean section. Failed epidural occurred in 17%, and now we've gone from 5 patients to 38. 38 of patients with an average, average weight of 136 kilos got spinal anesthetics for their thing. The time to the first dose, there's no difference between a CSE and a single-shot spinal. There were 4 failed anesthetics. And by the way, in this group, spinal anesthesia was the backup for the failed epidural in the obese. So in this reporting, they're saying single-shot spinal anesthesia. So remember, this is just reporting their observations in that one, and that's what this group has changed in terms of their practice in 2013. And 2013 was that year where we saw the Boston bombing of the Boston Marathon, as well as Rob Ford was mayor of Toronto. Boy, we've come a long way. Here's showing this, and one of the things was CSEs and epidurals show little difference in early recognition of catheter failure. Boy, isn't that an interesting conclusion, as Brendan's trying to convince us to do this epidural and CSE when there's very little difference in early recognition of catheter failure. So let's look at single-shot spinal anesthesia. If it's as bad as it's said, there can't be any studies out there looking at it. Well, here's a study comparing CSE and single-shot spinal anesthesia in morbidly obese. So they have 20 patients who got single shot. We have 20 patients who got a CSE. Average weight, I would argue, we'll all agree that we would call these morbidly obese. The average BMI is around 50. The time from insertion of the introducer to drug injection was, you can see, about 3 minutes in both groups, 3 minutes in both groups. Procedure completed within 10 minutes and 70%, 95% with the CSE, and you can see the number of attempts with the single shot is a little higher. But notice at no point do they say that you shouldn't be doing it, you know, in all those cases. And none of them was there a high block, none of them had a failed airway, none of them had those concerns. So we're starting to see, and the purpose of this paper was to argue that CSE will increase your speed of achieving it. However, the thing to realize is that it is an appropriate technique for that. So Brendan, hey, how many epidural catheters needed to be injected in that CSE group, right? Because that's what we're worried about. How many, Brendan?
In our study?
No, in this one.
No idea, I'm not.
That would be 0, Bob. None of them needed to be injected. So in reality, if we were to look at this, this is really a study of single-shot spinal anesthesia because all 40 of them had a single shot. And that makes Brendan very sad. So let's look at the study that Dr. Carvalho tried to convince us as we looked at this. And, you know, I think the key to this study is that you see, he sits there and tells you he doesn't do it, yet this is a study of taking a look at the dose of spinal anesthetic that's necessary. Average weight, there's no question these were obese. I don't know how he found these patients in the Stanford area, because I didn't think anybody was obese there, but he was able to find 42, average BMI 48, and they got randomized. And I think the key to this is, notice he defines success for induction, and that's the red. And one of the things that I'll always teach my residents, and I think the most important thing is, so he called success because they got a level. And the thing I would always stress around, remember, patients don't pay for levels, they pay for anesthesia. So who cares what the success was? Look at the successive blocks. And what he's showing us, and very nicely concluded, that the ED95, the dose necessary for 95% to have success of operation, is about 15 milligrams. And the reason I thought this was so important, because Brendan very nicely helped us identify one of the problems with single-shot spinal anesthesia. We spend so much time worrying about the dose and reducing it. No wonder there's a high failure rate. What he advocates, at least my interpretation, and he can disagree, was that we should probably give the dose that we normally would, despite this decreased CSF volume, to get that 95%. So I don't think he's advocating for 15, but I would absolutely feel comfortable with 12 milligrams for a spinal anesthetic. And I would argue that he too, as based on this study. So we'd have to ask Brendan, would you ever do a single shot spinal anesthesia for a morbidly obese parturient for an elective C-section? No, absolutely, positively never. However, here's a retrospective review of data from Stanford. Remember it was spinal anesthesia in BMI. So we can see here, 1/3 of those with a greater 40 kilograms BMI, 1/3 of them received single-shot spinal anesthesia. So you can see spinal was used much more heavily in the non-obese, but even as they went up, 1/3 of those did get a single-shot spinal anesthetic. And by the way, in this study, no spinal anesthetic required GA, but if you look at it, one patient who did get the CSE, this preferred technique, did require general anesthesia. So despite this concern, and by the way, Alex is sitting there smiling, I'm saying to him, thank you. I am a hypocrite. That's all I can say on that. Let's look at this again. So morbidly obese, greater than things, the dose they used, remember, he's sitting there saying, Bob Kaiser's not going to be able to tell a dose. We don't, let's look at the dose they used. 12 milligrams of bupivacaine, 10 mics of fentanyl, 200 mics of morphine. Time from the OR to incision was 36 minutes, incision to uterine incision 15, uterine incision to delivery 2 minutes, and total OR time really is quite impressive at about 2 hours. And they go on to postulate that the increased time for the CSE may have contributed to longer OR time. So it sounds like to me he's saying single shot's the way to go, right? Because the longer CSE time contributed to that. And the failure to obtain CSF with the CSE may occur in 3 to 5% of CSE techniques. So an interesting study that's coming from Stanford. And he's sitting there saying, I can't believe I said that. And he's also saying, I have no idea why I took off my glasses. So, let's look at the SCORE project, because it is really important with that. 142 morbidly obese for elective C-sections. So before we go to the SCORE project, this comes from the obstetric literature. 121 spinal anesthetics in morbidly obese, more number of attempts, and rather than having high spinals, the biggest problem they had was this failure to establish an insufficient duration. That actually was greater, and that's why I actually give Brendan huge credit, because he did influence my practice, and that I did start using the routine, what I would use for a non-obese patient, because I have now been convinced that looking at this insufficient duration to me is a greater risk. And as we saw that obese patient who had the endotracheal tube, most likely was because the spinal didn't last long enough. Let's look at the SCORE project, and I think the key is they look at high neuraxial anesthetics. Notice the term, what was that Brendan used was high spinals, but if I'm reading this correctly, it says high neuraxial anesthetics, and included spinal end epidurals. So we're really not quite sure, was it associated with the spinal or the epidural from that level? And we look at this, obesity is a factor. The problem with this is we got to go through this, and as we remember this, and again, I think Brendan nicely summarized, while we're doing this, we take the extremes of viewpoint, and I always really will advocate for judgment, but I think the important point on this, we have to be careful of these types of things. We see this and we say, oh my gosh, look at this. We had, on this one, we had total high 58 out of, by the way, 257,000. So it's really, it seems excessive, but we have to be very careful on that. We're not there. We don't know what dose they use. We're not sure of this. And it's like sitting there saying, yesterday I went outside and it was raining. And so I'm never going to go outside again because every time I go outside, it's raining. Well, it's hard to base it on a single isolated case report. I think we need to be aware. And I think while we look at this, it's always a risk, but it is a risk even with just spinal alone. And I'll advocate for using good judgment when using this. How about asking the patient? We've been very patient-centered this meeting, and I thought that's been great. We've gone away from the VAS for the patient as compared to how satisfied they were. Here's 1,500 consecutive C-sections broken up into obese and non-obese, and you can see the control, and the number of spinal anesthetics is 446 for the control, 482 obese, and 61 morbidly obese. And really, they just asked them, how do you rate the anesthesia? And you can see in the obese, they preferred the spinal anesthetic over the epidural. Consistently better anesthesia with the spinal. So we have to remember this as we are going for greater patient satisfaction, that they're experience greater excellent anesthesia and as compared to the other groups. And if you ask Brendan, I bet you he would want spinal anesthesia for his cesarean section. What is the effect of spinal anesthesia on the obese? Here's, for every increase in BMI, the umbilical cord pH decreases by 0.01. So we have to be aware of that. And I kind of addressed it a little bit yesterday, because I do think it's a unique group in which there is greater aortocaval compression, and the ability to tilt the obese is a lot less. You can imagine trying to tilt the table 15 degrees on those patients that Brendan demonstrated. And by the way, if anybody noticed, was that patient in left uterine displacement? No, because you can't do it. They're going to fall off the table. And that's why I start seeing this. And so I think we have to be careful in these patients and try to tilt them as best we can. And Brendan said, but Bob, I don't believe in tilt. I thought you didn't believe in tilting. And I'm starting to rethink it. I probably don't, but I do have the bigger picture here. So since I have the bigger picture, it's my say. How about, should we use preservative-free morphine? Boy, there's been a lot of debate. Should you add spinal morphine to your patients who are getting spinal anesthesia that are obese? Here's 5,000 women, and looking at the weights, and you can see here the dose of morphine was either 3 milligrams of epidural and 0.15 milligrams intrathecal. And boy, wasn't that nicely presented when they talk about the use of neuraxial opioids and how there's less respiratory depression. I know, and Joy said that. I mean, it's great. We've got to remember that, and we need to remember that in our obese group. When the Stanford group did report it, they did use neuraxial morphine, because in this series, there's no cases of respiratory depression. And in fact, if you don't give them neuraxial opioids, there's a higher chance that they'll get parenteral opioids, which definitely has a much higher risk in this patient population. So really one of the take-home messages, if you use, when you use your neuraxial technique, to make sure you include neuraxial opioids with your technique. So why do spinal anesthetics fail? When we looked at this 800 spinal anesthetics for elective cesarean delivery, 4 failures because they just didn't achieve a level. 37 required supplementation, fentanyl, and it's most likely due to the length of the procedure. And I think we've already seen a little bit of that when we've looked at this. There's been some concerns. I remember when I was a resident, I was taught in 1992 to reduce my dose of medication because of this concern. And ever since, as I said, Brendan has changed my practice. When that study came out and I started using the dose I normally would, I've not had to switch to general anesthesia because of an inadequate block. And I realized he really had changed. And when you look at that varicella study, where they had inadequate length, and it was most likely in the majority of those cases were spinals, was because of the fact we had been so ingrained you had to reduce the dose. And when you went the higher dose, you had a greater chance of success. You know, when things go bad, it's easy always to point fingers. People who attempt to switch the blame are afraid to fail. We've all been afraid to fail before a game, but it shouldn't stop us from continuing and doing what we have to do to get it done. So I'll argue Brendan is doing exactly that. He's standing there pointing his finger at the spinal anesthesia. Don't be afraid. And I think that's the key to that. Why do patients fail? I mean, spinals fail? It really is. It's just failure to obtain CSF. It's a classic thing. You chose the wrong local anesthetic, but it really very unlikely to fail. So you have a technique that's extremely unlikely to fail. Why not offer it for an elective cesarean delivery? Here's BMI and postural puncture headache. I just threw this in because I thought it's interesting. Here's a retrospective review of 18,000 anesthetics. And you can see this group had 125 accidental dural punctures, and there was no difference in postural puncture headache. So, you know, I'm not saying that spinal anesthesia, these were all epidurals in this group, but there is no higher risk. And in fact, another group goes on to say that it's protective. This is a review of 13,000 neuraxial anesthetics. They had 518. So here's the take-home message. You want to get your epidural in this place because they did more cases and had a lower wet tap rate as compared to this one, which did 5,000 less neuro and had much higher accidental dural puncture rate. But the key to this, no difference in a need for epidural blood patch, but it was a slightly lower. So I think the take-home message, if you do get an accidental dural puncture in the obese, there's not a higher risk. There's some suggestion that it may be protective, but in reality, when it comes down to it, the need for epidural blood patch is no different, so it's probably not much different. So hopefully you will now consider, I'm not asking you to do it, but consider it. Duration of cesarean delivery is longer, so I always will add epi. Remember, I work in an academic practice. Technically more challenging, no question about it, but not impossible. I'll argue don't decrease the dose. You know, I do agree with Brendan that, you know, we see this variable CSF, but my concern is that when you look at the literature, at least the cases where there's the worry of high versus inadequate levels, I'll argue the inadequate levels outweigh those of high spinals. Do add preservative-free morphine. I think they can be benefit and be prepared for the possibility of a high block. So, as Brendan already very nicely pointed out, you have to take one side or another. It really makes it for a great lecture. It's entertaining. It allows us to review the literature. It's funny how we both look at the same studies and really try to argue it different, but it really allows you to. Because in reality, let's look at this. If we were going to do spinals on these patients, I'll argue I would not do a spinal anesthetic on this guy. You know, I don't think I could intubate him if I got into trouble. And I probably would either consider epidural, I probably would do a CSE. Whereas on this guy, who has a really pretty decent airway, but both being morbidly obese, I bet you even Brendan would probably do a spinal anesthetic. Would you consider it? How about this? Would you do it? I mean, not do it, would you consider it? Yeah. He's shaking, by the way, he's shaking his head yes. So, he's shaking his head yes.
Yeah, just to get him to shut up, I'll just agree with anything.
He wants to go out and get that Philly cheesesteak. So I think that's what we're trying to say here. And, you know, I'll throw this out there. You know, this goes back to 1969. 8 obese individuals where they got spinal anesthetics. And it wasn't that. They argued that the PaO2 would increase. And I think what it really just shows that this has been around for a while. It's a known technique. And, you know, I thought it was nice. Alex talked about Shakespeare, and so I'm going to end with a quote with Shakespeare. This above all, to thine own self be true, and it must follow as the night is the day. Thou canst not then be false to any man. And remember that when considering single-shot spinal, you know, to thine own self be true. With that, I'd like to say thank you very much. Thank you for a really strong participation. I'll ask the panelists to come up, and what we'll do is, or should we come up? Do people have questions, or do we want to get out? Does anyone have questions? Okay, so we'll have the panelists come up and we'll answer any questions. Thank you very much.